Welcome back to the deep dive. Usually when we sit down behind these microphones, the vibe is pretty relaxed. We're here to explore, to follow curiosity wherever it leads, to find those little nuggets of wisdom that make you the smartest person at the dinner party. But today the mood in the studio is different. It's a little tighter, the air conditioning feels a bit colder.
That's because today isn't about dinner party trivia. Today is about survival.
Exactly. We are shifting gears from nice to know to you absolutely must know this. We are simulating a high-stakes scenario. I want you, our listener, to imagine you are standing in a sterile hospital hallway. You're wearing a suit that's maybe slightly too tight. Your palms are sweating. You're a postgraduate student, and you're about to walk through that door to face the examiners for the MD anesthesiology finals.
And not just any finals. We're channeling the spirit of the Gujarat University exams.
Which I am told are legendary.
Legendary is one word for it. Rigorous is probably the polite word. A trial by fire is probably the most accurate. In these exams, you can't hide. The examiners are not interested in whether you've memorized a definition from some review book.
Right.
They want to know if you think like a consultant. They want precision, they want safety, and they want to see you derive clinical management from the first principles of physiology.
And that is where you come in today. You are stepping out of your usual role as our friendly expert. Today, you are the senior faculty. You are the external examiner. You're the one peering over the top of your reading glasses, waiting for me as the student to slip up on a basic concept.
I accept the role. And I'll warn you right now, I'm gonna be pedantic. I will stop you if you waffle. Because in that exam, and more importantly in the operating room, the difference between a pass and a fail, or a safe patient and a catastrophe, it's all in the details. You can't just kind of know respiratory mechanics.
That sets the stage perfectly. Our topic today is the big three of respiratory physiology: diffusion, lung compliance, and airway resistance.
The pillars. They are the absolute pillars. If you understand these three, you understand mechanical ventilation. You understand why a patient with COPD needs a completely different strategy than a patient with ARDS. If you don't understand these, well, don't even bother walking into the exam hall.
We have a massive stack of sources to get us through this. We've got the heavy hitters, Guyton and Hall for the hardcore physiology, Miller's anesthesia for the clinical application, and of course Nunn's applied respiratory physiology, which is, it's basically the Bible for this topic.
It is the Bible.
Our mission today is to take all this dense material and translate it into a structured 20-mark exam answer.
And crucially, to identify the Viva traps. The places where very smart students say very stupid things and fail.
Okay, let's start with part A, the framework. Before we dive into the math and the graphs, how do we frame this for the exam? If I get a question like, discuss the mechanics of gas exchange, where do I even begin?
Yeah, you begin with structure. You have to step back and look at the whole system. You see, respiration isn't just breathing in and out, it's a relay race.
A relay race, I like that.
Step one is ventilation. That's the bulk flow of gas. Moving air from the room, down the pipes to the alveoli, that is where resistance and compliance live. They are the gatekeepers for ventilation.
Getting the air to the finish line.
To the start of the next leg, yes. Step two is diffusion. That's crossing the border.
Right.
Getting from the gas phase into the blood. Step three is perfusion, transporting it away in the bloodstream. Today, we are obsessed with step one and step two, the barriers. Getting it there and getting it across.
Getting it there and getting it across. Simple.
Exactly. And you most immediately link this to anesthesia. Why do we care? Because general anesthesia fundamentally breaks these mechanics.
We break them.
We destroy them. Think about it. We paralyze the muscles. There goes your pump. We lay the patient supine, or in Trendelenburg, there goes your functional residual capacity, your FRC. We shove a plastic tube in the windpipe. There goes your natural airway resistance and humidification.
Okay, when you put it like that.
Every single general anesthetic is essentially a controlled, induced, restrictive lung defect. If you don't understand the mechanics of the system you are breaking, you are flying blind.
That is a terrifying but extremely effective way to look at it. A controlled, induced, restrictive lung defect.
It is the truth. And in the ICU, when you're managing ARDS or severe bronchospasm, understanding why a lung is stiff, which is a compliance issue, or why it's obstructed, a resistance issue, that is the difference between successful weaning and causing barotrauma.
And looking at the past papers, These topics are frequent flyers. I'm seeing long questions. Describe factors affecting lung compliance. Discuss diffusion capacity. These are the big 10 to 20 mark questions.
Yes, but there are also snipers in the short notes section. You might just get a prompt like Fick's law, or hysteresis, or Reynolds number. You have 5 minutes to write down everything you know coherently.
And in the Viva?
In the Viva or the OSCE, they might just hand you a flow volume loop or a pressure time scalar from a ventilator and say, interpret this. If you hesitate, you lose.
Okay, let's attack the first pillar, Part B, diffusion. The outline calls this absolutely essential.
It is the bedrock. It is the entire point. If the oxygen doesn't cross the membrane, nothing else matters. You can ventilate them with perfect mechanics until the cows come home, but if diffusion fails, the patient dies.
Okay, let's role play. I'm the candidate, you're the examiner, you ask me. Define diffusion.
Go ahead, define it for me.
Okay, I'd say it's the movement of gas from an area of high pressure to an area of low pressure.
Sharp inhale. Stop. You just lost marks. You were too vague. You need the precision of a physicist here.
Okay, correct me. What's the perfect answer?
You must say. Diffusion is the net movement of molecules from an area of higher partial pressure or concentration to an area of lower partial pressure or concentration. And then you add the crucial part. It is a passive process driven by the kinetic energy of random molecular motion.
Random molecular motion. That's the key phrase.
It's absolutely crucial. You have to emphasize that this costs no energy, no ATP is burned. It is pure Brownian motion. Picture a billiard table with a million tiny balls all smashing into each other constantly. They're all bouncing randomly.
Right.
But if you have more balls on the left side than the right, statistically, just by pure chance, more will bounce over to the right. That is diffusion. It's a statistical event.
Got it. Passive process, kinetic energy. Okay, now let's talk anatomy. We need to visualize the barrier, the alveolar capillary membrane.
Guyton calls it the respiratory membrane. For the exam, you need to be able to draw this, and you need to appreciate the biological engineering here. It is unbelievably thin. We're talking about 0.2 to 0.6 micrometers.
I always struggle to visualize micrometers. Can you give me a comparison?
Okay. A red blood cell, the little bus that carries the oxygen, is about 7 micrometers wide, this membrane. It's less than 1/10 of the width of the cell itself. It is tissue paper thin. It has to be, because distance is the enemy of diffusion.
Wow. And despite being that thin, it has multiple layers.
6 layers, and this is a classic Viva question. Name the layers of the respiratory membrane, starting from the air side and moving to the blood.
Let me try to peel that onion. Okay. Starting from the inside of the alveolus. Layer 1 would be the fluid and surfactant layer lining the alveolus.
Okay.
Layer 2, the alveolar epithelium itself. Then layer 3, the epithelial basement membrane. Layer 4 is a tiny little interstitial space. Layer 5, the capillary basement membrane. And finally, layer 6 is the capillary endothelium.
Perfect. 6 layers, all fused together into a barrier that's thinner than a wavelength of visible light. Now, combine that incredible thinness with the surface area.
It's the famous tennis court analogy.
It's a cliche because it's true. The total surface area for gas exchange in the lungs is about 70 square meters, a singles tennis court. But here is the image I want you to hold for the exam. Imagine that tennis court. Now take a small cup of tea, about 70 to 100 milliliters of blood, which is the amount in your pulmonary capillaries at any given moment.
Okay.
Now throw that cup of tea across the entire tennis court.
It would just be a mist, a very, very thin film.
Exactly. Guyton calls it a sheet of blood. It's not really blood flowing through distinct tubes at that point. It is a microscopic sheet of blood flowing over a sheet of air, separated by a membrane that, for all intents and purposes, barely exists. That's how you maximize exposure.
That's a really powerful visual, a sheet of blood. So when we talk about pathology, we're basically just messing up this perfect geometry.
Precisely. Anesthesia and disease are wars against geometry. If you have pulmonary edema, that tiny interstitial space swells up with fluid. The membrane goes from 0.6 micrometers to maybe 2 micrometers. To you and me, that's nothing. To an oxygen molecule, that is the Grand Canyon. It can't cross in time.
This is a perfect lead into Section 3, the factors affecting diffusion. The outline says this is exam gold.
This is where you apply the physics. The rate of diffusion depends on the physical properties of the lung and the chemical properties of the gas. Factor 1 is surface area, more court, more diffusion.
And clinically, that's reduced in emphysema or after a pneumonectomy.
Exactly. Factor 2 is thickness. Thicker wall, slower diffusion. That's your pulmonary edema, your fibrosis.
Okay, those are intuitive, the structure of the lung. But let's talk about the gas itself, because not all gases are created equal.
Right, not all. Correct. This brings us to the diffusion coefficient. This is where students get tangled up in two different laws, Graham's law and Henry's law.
Let's break them down. Graham's law is about size, isn't it? Molecular weight.
It's about molecular weight. Graham's law states that the rate of diffusion of a gas is inversely proportional to the square root of its molecular weight. In plain English, fat molecules move slow, skinny molecules move fast.
Okay, so let's look at our main players, oxygen and carbon dioxide. Oxygen has a molecular weight of 32, carbon dioxide is 44. So according to Graham, oxygen is lighter, so it should win the race, it should diffuse faster.
And if the lung were just a dry gas chamber, it would. But there's a catch. The membrane is wet. The blood is wet. The whole system is aqueous. So we have to bring in Henry's law.
Which is all about solubility.
Exactly. And Henry's law trumps Graham's law here. CO2 is vastly, vastly more soluble in water and tissue than oxygen is. We are talking about 20 times more soluble.
So solubility acts like a VIP pass to get through the membrane.
It's the best analogy. Because CO2 dissolves so easily, it doesn't just diffuse across the membrane, it rockets across. The solubility factor is so powerful that CO2 ends up diffusing about 20 times faster than oxygen, even though it's a heavier molecule.
That's the aha moment. That explains the clinical picture we see in the ICU all the time.
It explains type 1 respiratory failure, absolutely. Imagine you have a patient with early pulmonary fibrosis or early pulmonary edema. The membrane is starting to thicken. The oxygen molecule looks at that thick, boggy wall and it struggles. It's not soluble enough to force its way through quickly. So the patient gets hypoxemic. Their O2 saturation drops.
But the CO2?
The CO2 doesn't care. It just breezes right through that thickened wall like a ghost through a door. So the patient is hypoxic, but their CO2 is normal or even low because they're hyperventilating to compensate.
So if I see a patient with a known diffusion defect who actually has a high CO2,
you should be very, very worried. It means the defect is catastrophic, or the patient is physically exhausted and can't maintain the work of breathing anymore. You are approaching respiratory arrest. Hypercapnia is a very late and very ominous sign in diffusion-limited diseases.
This leads us directly to Section 4, Fick's Law of Diffusion. The outline calls this very high yield.
If you are writing a long answer on diffusion, you must write this equation. Put it in a box, highlight it, make it the centerpiece. Vs, which is the rate of diffusion or the volume of gas transferred per unit time, is proportional to surface area thickness times U times P1, P2 dot.
To decode those variables for the exam answer.
Yeah.
A is area and T is thickness. Those are the lung anatomy parts.
Correct.
D is the diffusion constant we just talked about, which is basically solubility over the square root of molecular weight.
Precisely.
And P2 mine is the pressure gradient, the driving force.
And this leads us to the most important anesthetic relevance. Look at those variables. Can we change the surface area in the middle of a surgery? No. Can we fix the thickness of a fibrotic lung in the OR? No. Can we change the fundamental solubility of oxygen? No.
So we are left with the gradient. That's the only thing we can really touch.
Exactly. The only dial we have is Poton 1-1ers, the alveolar partial pressure of oxygen. By turning up the FiO2 on the anesthesia machine from 21% to 100%, we dramatically increase P-ton 1s. We brute force the gradient. We make the difference between P-ton 1 and P-ton 2 so massive that we can drive oxygen across even a sick, thickened membrane. That is why oxygen therapy works. It's applied Fick's law.
Okay, now here's a concept that I always find a little tricky, and the notes say it's an exam favorite. Diffusion limitation versus perfusion limitation.
This is a classic Viva trap. You need to be able to explain this clearly. It's about understanding what the bottleneck is. Is the barrier itself the bottleneck? That's diffusion limited. Or is the speed of the blood flow the bottleneck? That's perfusion limited.
Okay, let's break it down to the classic examples. The notes mention nitrous oxide, carbon monoxide, and of course, oxygen.
Let's start with nitrous oxide, N2O. When N2O enters the capillary from the alveolus, it does not bind to hemoglobin. It just dissolves in the plasma. Because it doesn't get eaten up or hidden away by hemoglobin, the partial pressure of N2O in the blood plasma rises very, very fast.
So it fills up the blood really quickly.
Instantly. Within a fraction of a second, about 0.1 seconds, the pressure in the blood equals the pressure in the alveolus. Equilibrium is reached.
And once you're at equilibrium, the gradient is gone. No more diffusion.
Exactly. No more gas can move across. The only way to get more N2O into the bottle is to bring in fresh blood that has no N2O in it. You have to increase the blood flow. Therefore, the uptake of N2O is perfusion limited.
Okay, that makes sense. The blood flow is the limiting factor. Now let's take the opposite extreme. Carbon monoxide, CODM.
CO is a nasty molecule. It crosses the membrane just fine, but then it binds insanely tightly to hemoglobin. About 240 times more tightly than oxygen. It gets sucked up by the HB instantly.
So it's hidden from the plasma.
Completely. Because it's bound up inside the red cell, it doesn't contribute to the partial pressure in the plasma. So as that red blood cell moves along the capillary, the partial pressure of CO in the blood barely rises at all. It never, ever reaches equilibrium with the alveolus.
So the gradient is maintained the whole time the blood is in the capillary.
The gradient is massive for the entire 0.75-second transit time. The speed of the blood flow doesn't matter because the blood never gets full in terms of partial pressure. The only thing slowing down the CO transfer is how fast it can physically wiggle its way through the membrane wall. Therefore, CO transfer is purely diffusion limited.
And this is why we use DLCO, the diffusion capacity of the lung for carbon monoxide, to test the membrane itself, right?
Exactly. We use tiny trace amounts of CO because its uptake completely ignores blood flow and purely tests the quality of the tennis court, the area, and the thickness. It's a pure test of the membrane.
Okay, so we have N2O on one end, CO on the other. Where does oxygen sit? The most important gas of all.
Oxygen is the Goldilocks gas. Under normal, healthy conditions, oxygen behaves a lot like nitrous oxide. It crosses the membrane and binds to HB, yes, but the hemoglobin gets saturated, and the partial pressure in the plasma rises quickly and equilibrates with the alveolus about 1/3 of the way along the capillary.
So normally oxygen is perfusion limited.
Normally, yes, it has a huge safety margin. There's 2/3 of the capillary length left over as reserve time.
And I'm guessing this is the exam trap.
This is the trap. If the membrane is thickened from fibrosis or edema, or if the blood is moving too fast, like an extreme exercise where cardiac output is huge, that equilibration might not be reached by the time the blood leaves the capillary.
Then oxygen
becomes diffusion limited.
So to summarize for the exam, oxygen is perfusion limited in health, but can become diffusion limited in disease or states of high cardiac output.
Correct. If you write that sentence, you get all the marks.
Let's just move to section 6 and nail down the clinical practice aspect. We've touched on this, but let's make it crystal clear. The main causes of diffusion defects.
2 categories. Thickening, that's your interstitial fibrosis, asbestosis, sarcoidosis, and of course pulmonary edema from heart failure or ARDS. And the second category is loss of surface area. That's emphysema, where the alveolar walls break down and you lose the fine structure of the tennis court, or a pneumonectomy, where a surgeon literally removes half the court.
And the anesthetic relevance here. Let's say in the pre-op clinic.
Pre-oxygenation. When you're pre-oxygenating a patient before induction, you're trying to fill their FRC with oxygen. If they have a significant diffusion defect, that process takes much longer or might be less effective. You have less of a safety buffer.
What about for a specific surgery?
The classic example is one lung ventilation for thoracic surgery. If a patient has a pre-op DLCO that's very low, say less than 40% of what's predicted, they are at very high risk. They are going to desaturate rapidly when you collapse one lung. The remaining lung, which already has a diffusion problem, just can't handle the entire cardiac output.
Okay, that covers the first pillar in detail. Let's move to the second. Part C, lung compliance.
Compliance. This is the concept that I find residents struggle with the most when they get to the math and the practical application on the ventilator.
Let's start with the Viva definition. Nice and clean.
Compliance is the change in volume per unit change in pressure. Delta V divided by delta P. It is a measure of distensibility, how easily does the lung stretch. And critically, it is the inverse of elastance. Elastance is the tendency to recoil.
So a compliant lung is a stretchy lung, like a party balloon. And a stiff lung is non-compliant, like a car tire.
Yes, that's a good way to think about it. The balloon has high compliance, easy to blow up. The tire has low compliance, very hard to blow up.
But the trap here is thinking about the lung in isolation, which it isn't.
Right. You must not do that. The lungs live inside a box, the chest wall. They are mechanically linked, so you have to consider 2 separate compliances. Lung compliance, or $6, and chest wall compliance, or CCWs, and they are arranged in series.
And the math for adding components in series is reciprocal, isn't it?
It is. This is a point you must state clearly. 1 $C total, 1 C lung plus 1 C chest wall.
Let's run the numbers on that because it's a bit strange. Let's say a normal lung compliance is about 200 mLcm H2O. And a normal chest wall compliance is also about 200 mLcm H2O. Logically, you might think the total should be 400. Or maybe the average 200.
Common sense would say that, but the physics says no. Let's do the math. $1,200 plus $1,200 equals $2,200, which simplifies to $1,100, so $1 total equals $1,100, which means the total compliance is 100 ml/CmH2O. The system as a whole is stiffer than either of its individual parts.
That is completely counterintuitive. Why does putting two stretchy things together make a stiffer thing?
Imagine trying to blow up that party balloon. Easy. Now imagine putting that same balloon inside a thick leather football and trying to blow it up.
Much harder.
Much harder, because you have to generate enough pressure to overcome the elastic recoil of the balloon rubber and the resistance of the stiff leather simultaneously. The leather constricts the balloon. The forces add up to resist you. It's the same with the lung and the chest wall.
Okay, that clicks. The chest wall is a cage. It restricts the expansion of the lung.
And anesthesia makes this even more complex. When you paralyze a patient, you might think, oh, the muscles are relaxed. The chest wall should be floppy and easy to expand, so compliance should go up.
Right, no more resistance from the intercostal muscles.
But gravity takes over. The abdominal contents, the liver, the spleen, the guts, they're basically a heavy fluid sac. When the tone of the diaphragm is gone, that sac slides up into the chest. It physically compresses the bases of the lungs. So even though the muscles of the chest wall are relaxed, the functional compliance of the whole system drops because the heavy liver is now sitting on your lungs.
Let's talk about the pressure-volume curve. The outline says this is exam gold. You have to be able to draw this loop.
You absolutely do. It is S-shaped or sigmoid. And you need to explain each part. At the bottom, at very low lung volumes, the curve is flat. This means the lung is stiff. Why? Because many of the small alveoli are collapsed, they're in a state of atelectasis. It takes a lot of initial pressure to pop them open. This initial opening pressure region is near the lower inflection point.
But once you pop them open, the curve gets really steep.
Yes, that steep part in the middle is the linear segment. This is where compliance is best. You get a lot of volume for a very small change in pressure. This is the sweet spot. This is where we want to ventilate the patient.
And then at the top, it flattens out again.
It flattens out again. This is the upper inflection point. The lung is now overdistended. It's like a balloon that's about to burst. It's very hard to blow any more air in. You're just stretching the collagen fibers to their limit.
So clinically, our goal with the ventilator is to keep the patient's breathing cycle between the lower and upper inflection points.
Exactly. This is the safe zone for ventilation. If you ventilate below the lower inflection point, you get cyclic opening and closing of alveoli. That's lectotrauma. If you ventilate above the upper point, you get overdistension and damage. That's volutrauma or barotrauma.
Now let's talk about that weird word on the curve. Hysteresis. What is it?
Hysteresis is a term from physics. It just means that the path of deformation depends on the history of that deformation. In the lung, it means the inspiratory curve and the expiratory curve do not overlap. There's a loop. The lung holds more volume for any given pressure during deflation than it did during inflation.
And the examiners will always ask why. Why does that loop exist?
Two main reasons. The big one is surface tension and the action of surfactant. To open up the lung on inflation, you have to overcome the surface tension at the air-liquid interface in millions of tiny alveoli. It takes energy. It's like pulling apart two wet microscope slides.
Right, there's a sticking force.
A huge sticking force. But during deflation, as the alveoli shrink, the surfactant molecules, which are spread out on inflation, get packed tighter and tighter together.
They get crowded.
Yes. And when they get crowded, they repel each other more strongly. This chemical repulsion massively reduces the surface tension. Because the surface tension is lower during deflation, the alveolus stays open at a lower pressure than the pressure it took to open it in the first place. That's the main reason for the loop.
And you cannot talk about surface tension without mentioning the law of Laplace.
You absolutely must mention it. Plush is equals 2TR dollars. The pressure required to keep a sphere open equals 2 times the surface tension divided by the sphere's radius.
What does that actually mean for our millions of different size alveoli?
It means that without surfactant, the lung would be unstable. A small bubble with a small radius would require a huge pressure to stay open. A large bubble needs less pressure. So without surfactant, all our small alveoli would collapse and empty their air into the big ones. The lung would collapse into a few big bullae. Surfactant breaks this law. It reduces the tension as the radius gets smaller. It balances the equation. It's what keeps our lungs stable.
Okay, let's look at section 9, a list of factors affecting lung compliance. This feels like a great short note question.
It is. So let's list them. Number 1, lung volume. As we saw on the curve, compliance is highest at normal resting volume, the FRC. It's low at very high volumes and very low volumes. Number 2, Surfactant. More surfactant or better quality surfactant increases compliance. Number 3, posture. A supine position reduces FRC and therefore reduces compliance. Number 4, anesthesia. As we've said, it reduces compliance. And number 5, the big one for clinical practice, pathology.
Right. So Section 10, conditions with altered compliance.
You have to divide this into 2 camps. First, decreased compliance or stiff lungs. The classic example is ARDS. Also, pulmonary fibrosis, severe pulmonary edema from heart failure. And don't forget chest wall problems. Severe obesity, kyphoscoliosis, or massive burn Eschers on the chest all reduce total compliance. In all these patients, you will need high driving pressures on the ventilator to deliver a normal tidal volume.
And the other camp is increased compliance. Floppy lungs.
Yes. The textbook example here is emphysema. In emphysema, the elastic tissue, the elastin fibers, are destroyed by enzymes. The lung loses its recoil. It's like an old, stretched-out rubber band. It fills very easily, super high compliance.
Well, high compliance isn't always a good thing.
No, it's terrible, because that old rubber band has no snap. It has no elastic recoil to push the air out, so the air goes in very easily, but it won't come out. The patient gets severe air trapping and dynamic hyperinflation.
Okay, that's a very clear distinction. Let's move to Part D, airway resistance, the third and final pillar.
Resistance. Symbol R. This is all about the opposition to flow. The definition for the exam. Resistance is the pressure difference required to generate a specific rate of airflow. The formula is 1R is off as delta P flow.
So where in the airway system is the resistance actually located? I think the intuitive answer for most people is in the smallest airways, because they're the most narrow.
That is the intuitive trap. It is wrong, and examiners love to catch students on this. The highest resistance in the entire tracheobronchial tree is in the medium-sized bronchi. We're talking about generations 3 to 7. That's the real bottleneck.
Why not the tiny ones?
Because the small airways, the terminal bronchioles, they are tiny individually, yes, but there are millions of them. They are arranged in parallel.
So it's like traffic on a highway.
Exactly. Think of the trachea as a single 6-lane highway. The medium bronchi are the first few major off-ramps. That's where the traffic jam always happens. The millions of tiny bronchioles are like the thousands and thousands of small residential side streets. Even though each street is narrow, the total width of all those streets combined is massive. So the air spreads out, the velocity drops, and the resistance is actually very, very low in the small airways.
So if a patient has small airway disease, like an early COPD,
It's often silent for a long time. This part of the lung is sometimes called the silent zone. You won't hear wheezing, and standard spirometry might be normal until the disease is very advanced and a huge number of those small airways are wiped out.
okay, you can't talk about resistance without mentioning Poiseuille's law. We have to recite this for the exam.
Yes. For laminar flow, which is smooth flow, resistance is inversely proportional to the radius to the power of 4. R is proportional to 104 Trellers. This is the golden rule of airway resistance. It means radius is king. Everything else is secondary.
Let's put that into numbers. If you have the radius of the airway, say from 50% bronchoconstriction in an asthma attack.
If you have the radius, the resistance increases by a factor of 2 to the power of 4. $2, 2 times 2 times 2 times 2 is 16. The resistance increases 16-fold.
That is a dramatic nonlinear number.
It's why airway issues are so terrifying, especially in pediatrics. A baby has a tiny 4-millimeter trachea. If they get 1 millimeter of edema from croup, they have lost 50% of their effective lumen. The work of breathing skyrockets by a factor of 16. They can't sustain that. They tire out and arrest very quickly.
What about the pattern of flow? Laminar versus turbulent.
Laminar flow is smooth, silent, streamlined, like a gently flowing river. It happens in the small airways where velocity is low. It follows Poiseuille's law. It is very efficient. Turbulent flow is chaotic, noisy, inefficient. It creates eddies and whirls. It happens in the trachea and large airways where velocity is high, or anywhere there is a constriction or a sharp angle.
And the Reynolds number, what's that for?
The Reynolds number, or Re, is a dimensionless number that predicts when flow will become turbulent. The formula is $3 velocity times diameter times density, viscosity. A number greater than about 2,000 suggests that flow will be turbulent. The key variable to note here is density. Turbulent flow resistance is heavily dependent on the density of the gas. Laminar flow, by Poiseuille's law, depends on the viscosity.
Is this why we sometimes use heliox? A helium-oxygen mixture?
Exactly.
Yeah.
That is the direct clinical application. Helium is a very low-density gas. If a patient has a critical upper airway obstruction, like stridor from a tumor, the flow through that narrowing is extremely fast and therefore turbulent. By giving a helium-oxygen mixture, we dramatically reduce the density of the gas they're breathing. This lowers the Reynolds number. It might convert the flow back to laminar, or at least it will significantly reduce the work of breathing against that turbulence. It buys you time.
Okay, clinical application time on the ventilator. Section 13. This is the peak versus plateau concept.
This is a daily ICU and OR skill. This is not just for exams. When you deliver a breath with the ventilator in a volume-controlled mode, the pressure in the circuit rises to a maximum. That is the peak inspiratory pressure, or PIP. Then, if you program the ventilator to pause for a fraction of a second at the end of inspiration, flow stops. The pressure in the circuit drops slightly and then holds steady. That steady pressure is the plateau pressure, or P-plat.
What do these two different numbers actually tell us?
They let you dissect the problem. The peak pressure, the PIP, is the pressure required to overcome everything. It has to fight the resistance of the endotracheal tube and the patient's airways, and it has to fight the stiffness or the low compliance of the lung and chest wall. The plateau pressure, on the other hand, is measured when flow is zero. Since flow is zero, the resistive component of the pressure drops out of the equation. Plateau pressure purely reflects the elastic recoil of the system. It is a direct measure of compliance.
So we should be looking at the gap between the two numbers.
The gap is diagnostic gold. The difference, peak plateau, represents the pressure needed just to overcome airway resistance. So, scenario A, the alarm goes off. Peak pressure is high, say 40, but the plateau pressure is normal, say 20. There's a huge gap of 20 between them. Your diagnosis is a resistance problem. You should immediately think bronchospasm, a kinked tube, the patient biting the tube, or a mucus plug.
Okay, and scenario B.
The alarm goes off, peak pressure is high, 40, but this time the plateau pressure is also very high, say 38. There's only a tiny gap of 2 between them. Your diagnosis is a compliance problem. The lung itself is stiff. You should think ARDS, a new pneumothorax, pulmonary edema, or maybe massive abdominal insufflation from the surgeons.
That is the so what for the exam. If the examiner asks, the high-pressure alarm is sounding, what do you do?
Yeah.
The first thing you say is, I will perform an inspiratory hold maneuver to check the peak and plateau pressures to differentiate between a resistive and a compliance issue.
Exactly. It differentiates the diagnosis instantly and tells you where to look first.
Let's just list off the main conditions with increased resistance for Section 14.
Sure. So asthma and COPD. Bronchospasm reduces the radius, remember, 4th orbit hours. This causes massively high resistance. Secretions also play a big role. Then you have upper airway obstruction. A tumor, a foreign body, croup in a child. This causes turbulent flow. And then crucially, anesthetic equipment. This is on us. Using an endotracheal tube that's too small for the patient, a size 6 instead of an 8. Using a long, convoluted ventilator circuit. Having sharp angles in the connector, we are the ones adding this iatrogenic resistance to the patient's breathing.
Okay, let's move to Part E, integration and anesthetic correlation. Section 15 and 16, this is where we put it all together. How do these three concepts interact in the operating theater?
They interact to define the time constant of the lung. This is a critical concept. The time constant, often represented by the Greek letter tau, is equal to resistance multiplied by compliance. It tells you how quickly a unit of the lung will fill or empty. One time constant is the time it takes for the alveoli to fill to about 63% of their final volume. You need about 3 to 4 time constants to get to 98% full or empty.
So what does that mean practically? Let's take a patient with high resistance, like in severe asthma or COPD.
A high resistance means a large or long time constant. The lung fills slowly, and more importantly, it empties very slowly. If you ventilate this patient too fast, they won't have enough time to exhale completely before the next breath starts.
So the air gets trapped.
The air gets trapped. This is called autopape, or breath stacking. It can lead to dangerously high pressures in the chest, it can reduce blood pressure, and it can even cause cardiac arrest just by ventilating too fast. For these patients, you must use a slow respiratory rate and a long expiratory time, an IE ratio of 1.3 or even 1.4.
And what about the opposite? A patient with low compliance, like in fibrosis or ARDS.
A low compliance means a very small or short time constant. The lung is stiff and it snaps shut very fast. These patients fill quickly and they empty very quickly. You don't need a long expiratory time for them. In fact, they often do better with faster respiratory rates and smaller tidal volumes.
Now let's really focus on Section 16, the effective anesthesia itself. The outline marks this as very high yield. We've said that we break the physiology.
Let's list the crimes we commit against the lung every time we induce anesthesia. Number 1, FRC reduction. As soon as you induce anesthesia, the FRC drops by about 15–20% in a healthy person. In an obese patient, it can drop by up to 50%. Why? There's a loss of chest wall muscle tone, and the diaphragm moves upwards, a cephalid shift, as the abdominal contents push into the chest.
Number 2.
Atelectasis. Because the FRC drops, the lung volume often falls below a critical point called the closing capacity. When this happens, the small airways in the dependent or bottom parts of the lung collapse at the end of expiration. The gas behind them gets trapped and absorbed, and the alveoli collapse.
And that leads to number 3, VQ mismatch.
It does. Those collapsed alveoli are still getting blood flow, they're being perfused, but they are not getting any ventilation. That is the definition of a shunt. That shunt is a direct cause of hypoxemia under anesthesia.
And what's the last crime?
Blunted reflexes. Anesthetic agents blunt a crucial protective reflex called hypoxic pulmonary vasoconstriction, or HPV. Normally, the lung is smart and it constricts the blood vessels going to areas of low oxygen, diverting blood to the good bits of the lung. Our drugs weaken this reflex, making the VQ mismatch even worse.
And then on top of all that, we add the surgical factors. You mentioned pneumoperitoneum and Trendelenburg position.
The perfect storm. The surgeons inflate the abdomen with CO2 for laparoscopy. That's the pneumoperitoneum. It physically pushes the diaphragm way up into the chest. Then they put the patient head down in Trendelenburg. Now gravity is pushing the entire abdominal contents onto that already elevated diaphragm. The FRC is absolutely crushed. Compliance plummets. Resistance rises because all the airways are being compressed. Your peak pressures will skyrocket.
What is the anesthetist's primary move to counteract this perfect storm?
You have to recruit the lung and keep it open. The primary tool for this is PEEP, positive end expiratory pressure. PEEP applies a constant back pressure that helps to push the FRC back up towards normal. It splints the small airways open, which can actually reduce resistance, and it reinflates those collapsed alveoli, which improves compliance and reduces shunt.
But it's a balancing act.
A delicate balancing act. Too much PEEP can overdistend the healthy parts of the lung. It can impede blood flow back to the heart and drop your blood pressure. Finding the optimal PEEP is one of the true arts of anesthesia and critical care.
Okay, last section. Part F, exam integration. We need to arm the listener with comparison tables and common diva traps, section 18 and 19.
For sure, you need to have these ready to go. Table 1, diffusion limitation versus perfusion limitation. You should be able to draw a simple graph of partial pressure in the capillary versus time. The line for N2O rises almost vertically and then goes flat. It hits the ceiling immediately, perfusion limited. The line for CO is almost completely flat along the bottom. It never rises, diffusion limited. The line for O2 rises quickly and flattens out about a third of the way along. Perfusion limited in health, but can become diffusion limited in disease, where the curve would be much less steep.
Great. And table 2. Compliance versus resistance in a ventilated patient.
Very simple. Compliance is a static property. It is reflected by the plateau pressure. Resistance is a dynamic property. It is reflected by the gap between peak and plateau pressure.
Okay, and the viva traps. We've talked about hysteresis and the site of airway resistance. What's another one?
The work of breathing trap. The examiner will ask what constitutes the work of breathing. A poor student will say something vague like, moving air. Wrong. You must be specific. You have to break it down. Work has two main components. 1, elastic work. This is the work done to overcome the elastic recoil at the lungs and chest wall. The work of overcoming compliance. This is about 65% of the total work in normal breathing. 2, resistive work. This is the work done to overcome airway resistance, moving the gas, and also tissue resistance, the friction of the tissues moving. This is about 35% of the work.
And this explains the different breathing patterns we see in disease states, right?
Yes. The body is smart. It instinctively adopts a breathing pattern that minimizes the total work. In a patient with pulmonary fibrosis, they have a stiff lung, so their elastic work is huge. To minimize this, they breathe fast and shallow. Taking shallow breaths minimizes the stretch and therefore the elastic work. In a patient with asthma, they have high airway resistance, so their resistive work is huge. To minimize this, they breathe slow and deep. Slower flow rates minimize turbulence and therefore resistive work. The patient is often smarter than the ventilator.
What about diagrams? Section 20. What are the 3 things the student must practice drawing right now on a napkin if they have to?
3 essential diagrams. Number 1, the alveolar capillary membrane, a simple schematic showing the 6 layers. Label the thickness and emphasize the huge surface area. Number 2, the static pressure volume loop. You must draw it. Mark the lower inflection point, the upper inflection point, and show the hysteresis loop clearly. Label FRC on the x-axis. Number 3, which we haven't discussed but is related, is a diagram of the west zones of the lung, showing how gravity affects perfusion and ventilation from the apex to the base.
And for structuring a long 20-mark answer.
It's a simple, fail-safe structure. 1. Definition. Use the precise physics-based ones we gave. 2. The formula. Write out Fick's law, or the compliance equation, or Poiseuille's law, put it in a box. 3. The diagram. Draw it large and label it clearly. 4. Factors affecting it. Always divide them into physiological and pathological factors. And 5, the most important part, anesthetic implications. This is the so what section. This is where you talk about Trendelenburg, PEEP, ARDs, one-lung ventilation. This is where you score the highest marks.
That structure seems bulletproof.
It is. It shows knowledge, it shows organization, and it shows clinical application. That is how you get 18 out of 20.
We have covered a massive amount of ground today, from the molecular dance of diffusion to the mechanical alarms of the ventilator.
It's a lot, but it is the fundamental language of our profession. If you can master this, you aren't just passing an exam. You are becoming a safer, more thoughtful anesthetist.
Let's wrap this entire deep dive up with a final summary. Section 21. Give me the high-yield bullet points to take into that exam hall.
Okay, here are the take-home points. 1. Diffusion is driven by the partial pressure gradient. CO2 is 20 times more soluble than O2, thanks to Henry's law, so diffusion defects cause hypoxia long before they cause hypercapnia. 2. Fick's law tells us area is good, thickness is bad. As anesthetists, we primarily manipulate the pressure gradient by changing the FiO2. 3. Compliance is delta V delta P. Total compliance is always less than lung or chest wall compliance alone because of the reciprocal formula. 4. The PV loop is your guide to safe ventilation. Ventilate on the steep part. Use PEEP to get onto it, but avoid the flat top of overdistension. 5. For resistance, radius is king. Remember 7 down growlers. Small changes in airway size from an ETT or bronchospasm cause massive changes in work. 6. For diagnosis on the ventilator, the gap between peak and plateau pressure is what discriminates a resistance problem from a compliance problem. And 7, the big one. Anesthesia is bad for the lungs. We reduce FRC, we reduce compliance, and we can increase resistance. We must be proactive in managing this with recruitment maneuvers and PEEP.
My final piece of advice to the listener. Grab a piece of paper, a napkin, anything, right now. Draw the pressure volume loop. Draw the hysteresis. Label the axes. Mark the inflection points. If you can draw it from memory, you own it.
Good luck. Go in there and be precise. You'll crush it.
Thanks for listening to The Deep Dive. We'll see you in the next one.